Professor Markus Peck, who is Associate Professor of Medicine and Vice Chairman of the Department of Gastro and Hepatology at the Medical University of Vienna, is well known to all of us, also because he's been, up to a few months ago, the General Secretary of EASL. And he will talk about what is the, which patients can be considered for interventional radiotherapy, selective interventional radiotherapy. Markus.
Well, Antonio, thank you very much, ladies and gentlemen, and the organizers, thank you very much for inviting me here. So I will briefly touch the topic of SIRT, which patients can be considered for SIRT. Now, I was asked to ask you a question, and I will actually ask you two questions. So here's the first one, just to get a feeling of how familiar you are with SIRT. Do you have any voting pads? I think that was explained. I hope so. Anyway, the question goes, does your center offer SIRT, and have you used SIRT for HCC treatment ever? And the possible answers are: the center does not offer SIRT, center offers SIRT, but you have not applied it for HCC treatment. Center offers SIRT, and you use SIRT in selected cases, and the center offers SIRT, and you use SIRT regularly as a standard treatment. So,
hands for that.
Oh, okay.
There you go.
Oh, here we are.
Beg your pardon, you got it.
Okay, so very good. Perfect. So 25% of the people, the center does not offer SIRT, and that's actually surprising because that means a lot of centers offer SIRT as an option. And then most people, when they have SIRT, they use it in selected cases, but not as standard treatment. Now this is something I think would be expected. There's really, I think, only Saudi Arabia where SIRT is almost like the standard and has already replaced TACE as the standard for BCLCB. Most other countries would do it like that. So now, Jean-François has already talked a lot about the theory of embolization, and here is a slide showing you the main difference between transarterial chemoembolization and selective internal radiotherapy. Now, when you look at the right-hand panel of this slide, you will see these two symbols of the tumor with the artery leading to the tumor, and on the right-hand side you see larger particles, and those are the ones used in TACE. So in TACE you block more centrally and not so much all the small vessels in the periphery, while with SIRT you use much smaller particles, usually below 100 micrometers, and with SIRT you block more the peripheral vessels and not to the same extent. So the mechanism of TACE is mostly the hypoxia, as explained by Jean-François, telling you that the chemo might not even be needed, while in SIRT the main mechanism is not the blocking of the blood supply, not the hypoxia, but the radiation that these particles deliver at the site of the tumor. And due to these differences in the mechanism of action, you might expect some differences in the application, because the way both therapies are brought to the tumor is essentially the same. You have the same arterial axis in the groin, then you take the catheter, advance it to the tumor. That's all the same for both treatments. Now, when we look at the potential application for SIRT, you have to say that SIRT most likely is not a curative treatment, so you'll find it on the non-curative right-hand side of the treatment algorithm, where it says palliative treatments. And so potentially what we could use it for would be either as a substitute or as an adjunct to TACE in intermediate stage HCC, or it's also conceivable that SIRT might be used as an alternative or an adjunct to sorafenib treatment in the advanced stage setting. So these are the two scenarios that are at the moment actively explored. Now, when you look at the absolute and relative contraindications for TACE, there's a number listed here. Mostly are fairly agreeable about amongst most people dealing with that. But there are some of these absolute contraindications where there might be a difference between TACE, that's blocking the arterial blood supply almost completely, so impaired portal vein flow, thrombus or malignant portal vein thrombosis is an absolute contraindication against TACE, but it might not be an absolute contraindication against SIRT. And at the same time, there are other things like untreatable arteriovenous fistula that are a contraindication against TACE, but you might be able to fix it. But this is an even stronger contraindication against SIRT, because if you have something like that, you might have a shunt that will lead to radiation pneumonitis, and that oftentimes might be fatal. So this was already alluded to by Jean-François. I will not go into that about how you select your patients. There's different methods, but in any case, why I'm showing you this is there are situations where you have to consider alternative treatments to TACE, and these alternative treatments have not been defined. And while at the moment mostly we think that sorafenib is this alternative treatment, it might well be that actually SIRT is an alternative treatment for TACE, as something that needs to be explored. So here, when you look at the decision making for TACE, when you have the situation that you need alternative treatments, where you have some contraindications, or you have patients that are more marginal, depending on which score you use, the HAP score, the BCLC-B subclassification, state score, whatsoever, or when you have a retreatment situation where your patient already has received TACE, but proves to be not really responding too well to TACE, which again is the right-hand side of this diagram. In those situations, you could find a reason why you would want to use SIRT. So here is the next question I'm posing to you. How do you predominantly select your patients with HCC for initial TACE? Do you use it by personal experience without any algorithms or scores? Do you use the BCLC staging classification only? Do you use BCLC staging classification plus BCLC-B subclassification? Do you use BCLC plus HAP score, or do you use BCLC-B plus state score? So please give me your current practice in this situation. Okay, so around a third is just using personal experience. Good. No, that's very important in medicine, you know. Around a third is just using BCLC C staging, and some are using also the BCLC-B subclassification. So, but total of 3 votes. Now that's good. Good. So let's move on. Now the thing is, when patients become ineligible for a certain treatment in a certain stage, for example, they become TACE ineligible in BCLC stage B, or they might have a problem with sorafenib in BCLC stage C, the question is, what do you do with those patients? The concept has been called stage migration in the guidelines, in the EASL guidelines, but probably also in other guidelines. And it means that you move to the next available treatment. So, but this is, of course, something that has to be reconsidered when you have a new treatment modality that's looking for its place in the algorithms. Now, when you look at the data that have been published on radioembolization in HCC, this work here is fairly important to give you an impression what's happening in Europe. The RE consortium, 8 European centers, or over 300 patients performing SIRT in clinical settings where the tumor board decides that SIRT should be given. What you see here is the median overall survival is 12.8 months. That doesn't really tell you too much. But when you start looking at the different BCLCC stages, you'll realize that when you apply SIRT in BCLC stage B, you have a median survival of 16.9 months. Now, when you consider the median survival that TACE usually offers you in that stage, it's between 20 and 24 months. So that means that SIRT in this setting does not really seem to offer a major survival advantage. Of course, oftentimes these patients are poor candidates. There's negative selection for these patients, so they might have been TACE before and so on. So there's good reason why the outcome might not be that good. But in any case, it's not given a very strong signal in favor of SIRT. And likewise, when you look at the BCLC stage C patients, the ones that are usually treated with sorafenib, where the median survival in SHARP was 10.7 months, you can see here with SIRT, median survival is 10 months. So again, I don't know, it's not really worse, but definitely does not really look much better than what you can achieve with drug treatment. So it's probably reasonable to study it. It's not a magic bullet at the moment. Now, when we look further, here this is data from the German, Austrian, Swiss prospective non-interventional study on sorafenib and HCC, where it's really interesting to see that when patients fail TACE in BCLC stage B, the median survival after they start sorafenib is 25 months. So this is actually a very, very long survival for TACE failures, and shows you that, especially when you compare it to the SIRT data that I just showed you, it's really questionable whether switching to SIRT is a great idea in these patients. Now, what do we have in comparison? So we have no prospective randomized trials at the moment, but I will show you what's ongoing. So what we do have is we do have retrospective comparisons. This one is from Riyad Salem from Chicago, where he compared 122 TACE patients with 123 SIRT patients over 9 years. And when you look at the primary endpoint survival, you could see that whether you look at all patients, 17.4 versus 20.5 months, non-significant, or when you just look in the BCLC stage B patients, the intermediate stage patients, where the survival is 17.5 versus 17.4 months, definitely no difference in the survival in these two groups. But when you look, of course, at secondary endpoints like time to progression and safety, you find that SIRT is better, owing to the fact that SIRT you can apply it more than once, but usually you don't have to apply it as often as TACE, and that, of course, is more convenient for the patient. Now, when we look at what's published on the comparison of SIRT versus sorafenib, here is a propensity score analysis from Italy, very recently published in Liver International, where they looked at 137 intermediate to advanced stage HCC patients that were not amenable to TACE. And when you look at the overall survival on the lower left-hand panel, you can see there's no difference. But when you match the overall survival with propensity score matching, you see there's even less difference between these two groups in terms of survival. So again, it shows that SIRT is probably reasonable, but in terms of survival, it will not offer a major advantage. However, it might well be that, or most patients would probably prefer a single SIRT treatment and then a fairly normal life without much side effect compared to a treatment that gives you, but not terrible, but maybe still meaningful side effects on a daily basis. So what is really ongoing, and that's good that this is happening, are the prospective randomized controlled trials with SIRT. And I looked at clinicaltrials.gov recently, and this is what I found. The first trial is a very small trial in Germany, so 24 patients, so that will not give you a lot of answers. But besides that, the next two trials are two fairly large phase 3 randomized trials where the use of SIRT versus sorafenib is explored in advanced stage patients. One is happening in Singapore, the Civanib. And the other one, the SARA, is the French trial where you can see almost 500 patients were included or will be included. And SARA seems to be recruiting faster than the Singapore trial, so most likely the French trial will be the first one where we will get data. And that will be an important trial, prospective trial, where we can position SIRT against sorafenib and see what we really get. And then we have 3 trials that are looking to compare TACE with SIRT. One is a trial called TRACE. It's happening in Belgium, planning to involve 140 patients. Then you have another phase 3 trial going on in Korea, and they plan to enroll 102 patients. And then last but not least, you have the Premiere trial, which is a trial happening in the US, and there they're also going to enroll 124 patients. And here TACE will be compared prospectively with radioembolization. And again, here we will learn how we can use TACE or TARE and in which situations. What's not ongoing at the moment is trials where you test consecutive treatment strategies. For example, do you rather use a SIRT or do you rather use sorafenib in failures to TACE? This is, of course, an interesting question, but this is not being addressed in these trials. So, to sum it up, TACE is the standard treatment for BCLC stage B patient, but confers probably only marginal benefit since it also harms patients. It's very important to select your patients. You can do that by using the scores, especially for retreatment. Jean-François already alluded to the ART score, which is, we think, quite helpful. Sorafenib is the standard of care for advanced stage HCC, but as already mentioned, it has relevant side effects, and also the efficacy is not perfect. SIRT exerts its action mostly through targeted radiation and less through blocking arterial blood supply, and so it can be applied in patients with more marginal liver function and also in patients at least with partial portal vein thrombosis, as long as the tumor burden is not too massive. Ongoing randomized trials will determine its efficacy and safety in intermediate or advanced stage HCC. And assuming that the effect is fairly similar, then cost effectiveness will be an important parameter for a potential large-scale implementation as routine intervention for HCC. Now, in Saudi Arabia, this is not that much of a question. However, in our economies, it might be a little bit different, and we will be really keen to see what, for example, NICE tells us about the use of SIRT versus sorafenib if the trials show what we expect them to show. Thank you very much.
Thank you, Mark. Am I correct if I assume that you're not saying that yttrium will supersede all TACE procedures, even if it is shown to be marginally more effective?
Yeah, I think so. First of all, the radioembolization needs certain logistics that are not available everywhere. You know, as Jean-François said, TACE is a fairly simple procedure, and the equipment you need is available everywhere. Now, for SIRT, you need the cooperation between nuclear medicine and interventional radiology. You need certain facilities, so it is more difficult to set up, and you will not have it so readily available. And the cost is significant.
Thank you. Any questions? Professor Dozi.
Could you comment a little bit further on the side effect profile, in particular for the arterial venous shunts you may have in the tumors? With the SIRT, you have much more smaller beads with a higher risk probably to have a systemic exposure than you have in TACE. Does it clinically matter? Is that something you can also assess by gamma camera, how much really is not taken up by the liver lesion?
So TACE, so SIRT, as we perform it, is a two-stage procedure. There's the angiography number one, that is just a preparation for the actual procedure, where you do the so-called shunt scan, where you inject some radioisotopes in order to assess how much the lung actually catches. And if there is too much radiation to the lung, you cannot do the procedure because it's too dangerous. At the same time, when you do this procedure, usually the interventional radiologist will also coil the gastroduodenal artery and maybe also some other small branches in order to avoid any backflow of the radioactive material, because when you embolize the stomach wall or when you embolize the pancreas, you have very, very severe side effects that you might not be able to control. So there's some danger here, and it adds a little bit to the complexity. On the other hand, it also helps you with not wasting too much of the expensive activity. So we do it 1 week ahead, and then we order the activity only when we see that we can actually perform it.
Thank you.